Hi, my name is Carmelo Messina from Milan, Italy, and together with my colleague Dr. Domenico Albano, which will do the live ultrasound part, we're going to show you the anatomy and the scanning technique of the median nerve. This first slide shows you a scheme of the origin of the median nerve at the level of the axilla. As you can see, the median nerve arises from the medial and lateral cord of the brachial plexus at this level and receives the innervation from the C6-T1 nerve roots. It has to be noted that at the level of the upper arm, the median nerve does not provide any motor or sensory function. Conversely, it provides motor function to the forearm and both motor and sensory function to the wrist and the hand. As you can see, the median nerve runs medially as they exit the axilla together with the ulnar nerve, and the ulnar nerve is located usually just behind in the posterior aspect compared to the median nerve. In the proximal to mid-upper arm, we have a very important landmark for identifying the median nerve, which is the brachial artery. In fact, we can easily look for the median nerve by searching this artery just after the axillary region. If we look at the proximal upper arm, which is here depicted in section 1, the medial nerve, we can see it travel anteriorly and laterally to the brachial artery and veins in the anterior compartment of the arm, just close to the coracobrachialis muscle. We can also see at this level the ulnar nerve, which is located within the anterior compartment, just posterior to the brachial artery. If then we move to section 2, a little bit distally, we see that the median nerve travels anteriorly, but it curves around the brachial artery medially to it and travels in the anterior cubital fossa, just a little bit posterior to the brachial artery. Then, if we still look at the course of the median nerve a little bit distally in the upper arm, we can see it running beside the brachial artery all the way from the axilla to the elbow. Here you can see 4 different sections that are showing us the course of the median nerve in the mid-upper arm, and you can see that the median nerve is gradually shifted toward the medial side of the brachial artery at all the level, and finally within the mid-distal upper arm, the median nerve is identified coursing between the bicep brachii and the brachialis muscles. The entrapment at these sides are quite uncommon, but of course the median nerve may be subject to trauma or other neuropathies in this region. And now we move to the live ultrasound of the median nerve at the upper arm that will be performed by Dr. Albano.
Before starting our ultrasound evaluation of the median nerve, we should make some consideration. To do this scan, we need high frequency linear transducers with frequencies ranging from 12 to 18 megahertz. Then we have to adapt our probe and settings of our machine to the part of the nerve that we are evaluating, because the nerves of the upper limb and of course the median nerve can be deeper or more superficial, as well as its branches. So to start the ultrasound of the median nerve, we can place the probe on at the level of the axilla and short axis to search for our anatomic landmark, that in this case is the brachial artery. This large vessel in the center of the image, and we can easily recognize the median nerve anterior and laterally to the brachial artery. Here we can identify the median nerve superiorly and laterally to the brachial artery. At this point, we should differentiate the median nerve from the other nerves exiting the brachial plexus, specifically the ulnar nerve, which is located medial to the brachial artery, and the radial nerve, which is deep deeper to the brachial artery. As you can see in this image, the radial nerve moving deeper. Okay, the median nerve is also close to muscle belly, which is laterally to the nerve, which is the coracobrachialis muscle on the lateral aspect of the median nerve. Then we can slide the probe to follow our nerve with the brachial artery in the medial aspect of the anterior compartment of the upper arm, where the median nerve and the brachial artery enter the bicipital fossa. As you can see in this image, the nerve and the artery have on the lateral aspect the biceps muscle, and on the medial aspect the brachialis muscle. So in the proximal part of the upper arm, the median nerve travels with the brachial artery, keeping the lateral position. However, in the mid part of the upper arm, you can see the median nerve that gradually shifts toward superficially and medially to the brachial artery here in the mid part of the upper arm. Always keeping the short axis, we can see the median nerve and the brachial artery approaching the elbow. Remember that in this compartment, the median nerve doesn't provide any sensory or motor supply, and generally it's not affected by entrapment neuropathies. And of course, the median nerve can be involved in traumatic injuries.
Now we move to the median nerve at the level of the elbow and proximal forearm. Before looking at the anatomy, we first have to consider that at this level the median nerve does not provide any sensory supply. Conversely, it innervates the entire anterior muscular compartment of the forearm, with the exception of the flexor carpi ulnaris and the ulnar aspect of the flexor digitorum profundus. So, definitely, the forearm muscles innervated by the median nerves are pronator teres, flexor carpi radialis, the palmaris longus, and the flexor digitorum superficialis. And here on the left you can see a scheme of this muscle depicted in red. Distal to the radial tuberosity, the median nerve gives rise to the anterior interosseous branch, and we find this branch in the cubital fossa. The anterior interosseous nerve runs downward to the carpus directly on the interosseous membrane and innervates the radial aspect of the flexor digitorum profundus muscle, the flexor pollicis longus, and the pronator quadratus. In this cross-sectional image on the right, we see the point in which the anterior interosseous nerve branches from the median nerve. As we note, the median nerve goes downward in a more ventral aspect, while the anterior interosseous nerve is located posteriorly and is directed into the interosseous membrane. Now let's look at the anatomy of the median nerve at the level of the elbow. From now we will have three important landmarks: the brachial artery, the pronator teres muscle, and, as we will see in the next slides, the ulnar artery. Right at the level of the elbow, the median nerve is situated medial to the brachial artery and courses between the brachialis and pronator teres muscle. Here there is another important anatomic landmark we may use as a reference. In fact, if we focus on the brachial artery, this is the point in which it bifurcates in the radial and the ulnar artery. Since this point, the ulnar artery will represent our landmark for looking at the median nerve. Now let's look at the course of the median nerve at the level of the forearm. In the upper part, we can use the ulnar artery as a landmark, as the median nerve continues in the proximal forearm along the medial aspect of the ulnar artery. Then, more distally, the median nerve courses between the two heads of the pronator teres muscle, the humeral head and the ulnar head. Now let's look at the median nerve in the distal forearm. Here it is usually simple to locate this nerve as it is placed in a quite superficial position. In the distal mid-forearm, the median nerve progressively leaves the ulnar artery and starts to travel in the fascial plane between the flexor digitorum profundus and the flexor digitorum superficialis muscle, and it is usually surrounded by fat. In the forearm, sites of median nerve compression includes the pronator teres, the biceps aponeurosis, and the flexor digitorum superficialis arch. One of the most frequent causes of compression at these sites is actually muscular hypertrophy. And now let's back again to the live ultrasound by Dr. Domenico Albano.
Let's move to the elbow, where the median nerve travels superficially and can be identified over this large muscle, which is the brachialis muscle, always medial to the brachial artery. Another anatomical landmark at this point is the tendon of the biceps, the distal tendon of the biceps muscle, which is located laterally. If we slide the probe distally, we can see the median nerve and the brachial artery becoming deeper, and at this level, these structures are located between the brachialis muscle and the pronator teres muscle. If we slide further the probe, you can see the brachial artery that bifurcates into vessels, which are the radial artery and the ulnar artery. This is important because the median nerve at this point travels for a short tract with the ulnar artery. The median nerve then penetrates the pronator and is located between the heads, the two heads of the pronator teres muscle, as you can see in this image. And this is a possible site of entrapment of the median nerve, mostly related to muscular hypertrophy. Then, if we slide further the probe, you can see the median nerve in the center of the image, which is located in this fascial plane between the flexor digitorum profundus muscles, deeper, and the flexor digitorum superficialis muscles, more superficial. You can also note how the median nerve is surrounded by hyperechoic fat tissue. If we take a look deeper, you can see the interosseous membrane as this hyperechoic line deeper if compared with the flexor digitorum profundus muscles, and you can see this small hyperechoic structure, which is the anterior interosseous artery. This vessel travels with a small nerve, a small branch, which is the anterior interosseous nerve. This is an important branch of the median nerve because it provides motor innervation to the radial aspect of the flexor digitorum profundus muscles, to the flexor pollicis longus, and the pronator quadratus. So when we have this aspect of entrapment of this nerve, we should evaluate the trophism of these muscle bellies. And if we go back to the median nerve, we can also see this tiny branch that approaches to the median nerve. Indeed, the median nerve gives rise to this small branch distally to the radial tuberosity, and then the anterior interosseous nerve becomes deeper following the anterior interosseous artery. But now, going back to the median nerve, we can see in the mid part of the forearm how this nerve becomes gradually more superficial. The median nerve tends to become more and more superficial before approaching the carpal tunnel.
Flexor digitorum superficialis and the flexor digitorum profundus tendon, and then enters the carpal tunnel. Before entering the carpal tunnel, the median nerve gives rise to the palmar cutaneous branch, which provides sensory innervation to the skin on the radial aspect of the palm. This nerve courses superficially to the flexor retinaculum and immediately on the ulnar side of the flexor carpi radialis. This nerve can be visualized in about 80 to 85% of individuals. At the wrist, the median nerve proceeds underneath the flexor retinaculum into the carpal tunnel and then divides into its ending branches, the common palmar digital nerves and the proper palmar digital nerves. Here, the median nerve it is located deep to the flexor retinaculum, lateral to the flexor digitorum superficialis tendon, and medial to the flexor carpi radialis tendon. And then, finally, within the carpal tunnel, the median nerve is located superficial and radial to the flexor digitorum tendons and superficial and ulnar to the flexor pollicis longus tendon. Let's move to the final part of live ultrasound.
Now, we can see just prior to entering the carpal tunnel, the median nerve, which is superficial to the tendons of the flexor digitorum profundus and flexor superficialis muscles. If we enter the carpal tunnel, we can see the medial nerve located just below the flexor retinaculum, also called transverse carpal ligament, which is this tiny structure. If we have some problems to recognize the median nerve, to differentiate the nerve from the other tendons, we have to recall that by tilting the probe in this way, we can note that the tendon alternatively become hypoechoic and hyperechoic due to the anisotropy effect, while the median nerve remains the same with its honeycomb appearance related to the hyperechoic fascicles surrounded by hyperechoic connective tissue. We can also evaluate the nerve in the long axis, but for an anatomic demonstration it's actually not so useful because it's not so easy to follow the nerve in the long axis. It can be useful when we see pathological changes of the nerve to evaluate on the long axis the nerve, which is more coarse and hypoechoic if compared with the tendons, which are hyperechoic and fibrillar in appearance. Before entering the carpal tunnel, the median nerve provides a small sensory branch, the palmar cutaneous branch, which is a very tiny structure that should be evaluated with a very high frequency probe. So it would be better to change our probe. We were using a 12-14 megahertz probe, and if you have available an acoustic probe, it would be probably the best to evaluate this small structure that is outside the carpal tunnel and is located just on the radial aspect of the median nerve and on the subcutaneous tissue, can be recognized on the ulnar aspect of the flexor carpi radialis tendon. This important branch provides sensory innervation to the radial aspect of the palm.
On behalf of me and Domenico Albano, thank you very much for listening, and we hope you may find this useful.